Queridos amigos, colegas, residentes, ecografistas todos, bienvenidos a este webinar de elastografía, gentilmente auspiciado por la empresa Datamédica, quienes representan en Chile a la marca de ecógrafos Mindray. La elastografía es una técnica relativamente reciente en el mundo de la ecografía, que se basa en la evaluación de la rigidez de los tejidos para identificar diversas patologías, fundamentalmente en la esfera de la neoplasia, y que ha mostrado resultados promisorios en los últimos años. Si bien es una técnica poco difundida en Chile, día a día empiezan a aparecer más requerimientos para realizar este tipo de exámenes, e incluso este año 2021, FONASA incorporó el código de elastografía, como muchos de ustedes deben estar enterados. Por lo tanto, es importante que nos mantengamos al día, que conozcamos esta técnica y que seamos capaces de entender cuáles son sus usos, sus ventajas y sus limitaciones. Para esta actividad de educación médica continua contaremos con la presencia de tres muy distinguidos colegas de los Estados Unidos. Nos acompañará para hablar de elastografía en hígado el doctor Nirvikar Dahiya, de la Clínica Mayo de Arizona. Para hablar de elastografía mamaria, la doctora Amy Patel, de Liberty Hospital. Y para hablar de elastografía tiroidea, el doctor Richard Barr, que es editor en jefe del Journal of Ultrasound in Medicine, una de las principales revistas de nuestro rubro. Así que les doy nuevamente la bienvenida, les agradezco por haberse inscrito y por estar interesados en conocer más, en aprender más y todos juntos en comunidad poder potenciar la modalidad del ultrasonido, que creo yo todavía tiene mucho que decir en el mundo de la imagenología. Gracias por acompañarnos. Muy bien, entonces para comenzar nuestro webinar, ahora vamos a escuchar la clase del doctor Nirvikar Dahiya. Él es radiólogo especialista en ultrasonido, jefe de la división de ultrasonido de la Clínica Mayo de Arizona, presidente del Comité de Parámetros Técnicos de Ultrasonido del Colegio Americano de Radiología y secretario ejecutivo del Comité de la Evaluación Vascular de la Sociedad Intersocietaria de Acreditación también de Estados Unidos. El doctor Dahiya tiene muy extensa experiencia en ecografía y en actividades de educación médica continua referidas a esta especialidad. Así que, sin más, les dejo ahora la clase del doctor Dahiya, donde hablaremos sobre los fundamentos básicos de cómo funciona la elastografía y su uso en hígado. Adelante, doctor Dahiya.
Hello, everyone. I'm Nirvikar here. I'm a radiologist at the Mayo Clinic, Arizona. Gives me great pleasure to talk at this webinar, and I thank Eugenio Zalaquett and his entire team for giving me this opportunity. Today, we will talk a little bit about elastography, which is a new tool on the ultrasound equipments. And we'll wrap it up by looking at how a liver elastography is performed. So one of the basic things which we have to be aware of is this property of viscoelasticity. This is a property inherent to tissue. And essentially what happens is that you are able to compress any tissue a little bit, and then it gets deformed and comes back to its original shape. Therefore, this is a time-dependent behavior. How do we measure this behavior? We can measure it with elastography. So what is elastography? And when I talk about elastography, most of the time in this lecture, I'll be talking about the shear wave elastography. There are multiple other type of elastographies. Initially, transient elastography was more common, but this is the thing which is much more reliable and much more objective. So to define what is shear wave elastography, it is essentially an imaging technique that quantifies tissue stiffness by measuring the speed of the shear wave in tissue. Now, how do we do that? because we are able to measure it since it's a mechanical wave. And a mechanical wave can only propagate in solid tissue. It can go on the fluid too, but essentially what we want from a diagnostic point of view is to measure it as it transmits through solid tissue. The elastography techniques use a dynamic excitation to generate the shear waves in the tissue, and they are monitored by a real-time imaging modality like ultrasound. So one of the things to remember is that a normal ultrasound wave is a longitudinal wave. As it moves through tissue at a certain speed, the particles within the tissue undergo rarefaction and compression. And the direction of the wave motion and the particle motion is essentially the same in a conventional ultrasound wave. When you have a shear wave, although the wave motion is similar, the particle motion is at 90 degrees to the insonation. That is the movement we want to measure. If you look at the way a drop of water falls into a river or any static portion of the fluid body, you will see that these ripples, they are formed on the outside and they go further out. In ultrasound, this is what we are trying to achieve. We are trying to send a continuous wave that continuously then sends these ripples to the outside. These are the ripples. The speed of these ripples is what we want to measure. And that defines the shear wave elastography. What does speed alone do? If you use an equation, which is basically based on the Young's modulus, the speed of the shear wave helps us to get a measure of the stiffness of the tissue. And that is really important. The logic being, for example, in liver, initially a normal liver has actually less stiffness. And as it gets diseased or fibrotic, its stiffness increases. So the speed also increases. And that's why it's an indirect indicator of the fact that fibrosis is setting in. This is the incidental beam of ultrasound that goes in, and these are the shear waves generated on the side. They are then measured. Here's an example which shows how the incidental beam generated the side movement of the shear waves. Those are measured. And they are measured again by using the shear modulus, which is basically the Young's modulus. Now, we do consider that when these waves go sideways, that the tissue is elastic, it's homogeneous, it is isotropic, and that the movement is linear. And anything that does not do that will change the speed at which the waves are going through this tissue. So in recap, the shear wave speed in a medium is related to the Young's modulus. And you don't need to remember this equation. The equipment is able to calculate the speed and is able to translate the stiffness into kilopascals and gives you a number. Estimating the shear wave speed, the underlying tissue stiffness is quantified. Low speed corresponds to soft medium, and a high speed indicates a stiff medium. Here is the illustration of the induction pulse. You have a shear wave that is generated, and then there is a detection pulse sent by the ultrasound beam that goes back to the transducer to calculate the speed of the shear waves. And that is essentially what we want to do. Now, as I alluded to earlier in the lecture, there are other components which are of elastography, which were initially popular, like the strain elastography or transient elastography. But essentially, most of the objective work nowadays is about point shear wave elastography or 2D shear wave elastography. Now, while both these methodologies generate the shear waves, what 2D shear wave elastography allows is once you put a ROI or a region of interest, you are able to make multiple measurements within that region of interest. So the number of images you have to take to calculate the stiffness are much lesser than what earlier you needed. There is a slide here that defines some of the terms which are used in elastography. I will not go in detail with this, but if you are reviewing this lecture, feel free to pause and read through them. So what about the diffuse liver disease we talk about and the role of elastography in that disease? It may be any pathway, but eventually a diffuse liver disease progresses to fibrosis. The pathway could be alcoholic, could be non-alcoholic, fat deposition, viral, any sort of insult on the liver disease eventually leads to fibrosis. Once the fibrosis sets in, it eventually leads to cirrhosis. And we all know with cirrhosis comes portal hypertension, liver failure, and possibility of getting a malignant change like hepatocellular carcinoma. So accurate staging of the degree of fibrosis becomes extremely critical in planning management and therapy in patients who are having fibrosis. Because early on in the disease, we can treat it and maybe even reverse it. How are we able to sometimes pick these up if we did not use elastography? The gold standard historically has been the liver biopsy. It's an invasive procedure. There is about 1% chance of complication. And then there is obviously a sampling error. We are taking a very small piece of the liver compared to the entire volume of the liver. The pathologists themselves within them have a fairly wide inter-observer variability on the way they are looking at the pathology slides and making their estimation. Among the non-invasive techniques, there are blood markers. None of them is perfect, but a combination of blood markers does increase the yield of detection. And then, of course, we have elastography, MRI and ultrasound. The MRI is extremely expensive, although it's a great tool. Ultrasound, very user-friendly, much more affordable, and easier to use even bedside. So here are some examples correlating with what happens when fat deposition takes place in the liver parenchyma. This is a normal liver, and you can see these beautiful hepatocytes with central nuclei. When patients have fatty deposition, then you have these droplets which are occupying most of the cell, and the nucleus is shifted to the periphery. Eventually, untreated, this could progress to steatohepatitis. Once you go into steatohepatitis, that means there is an inflammatory response by the liver to this disease. And that inflammatory response is sending all these lymphocytes and monocytes in, and also causing very early on some amount of mild fibrosis. You can use different strains to look at these fibrotic components, as in this NASH, we can see some more fibrous streaks around the cells. Eventually, these fibrotic streaks can become so big that you start having these macronodules and liver cirrhosis sets in. As we all know, once you have a cirrhotic liver, blood finds it really hard to get through it. There is large amount of resistance. That's when collaterals open up, patients can have bleeding episodes, spleen can become bigger, and patient has ascites. So this is a decompensated state of cirrhosis. What we want to do with elastography is to find the chronic liver disease earlier before it goes to a decompensated cirrhotic stage. Once you're in that stage, your mortality is fairly high. But we want to detect it while it is still being compensated in the early inflammatory regions. Now, how do we categorize this inflammation? Historically, pathologists have used different criteria. There is the ISHAC criteria, but the more popular one is the Meta-Weir classification. And it sort of simplifies things because the Meta-Weir classification, if you include no fibrosis of F0, then has 4 classifications within it. Now, F1 is when there is early fibrosis, and F2 is when you have occasional bridging between the portal veins or between the portal vein triads. Eventually, that bridging can extend to involve the central veins and then cause nodules. So F3 and F4 is higher progression of fibrosis within the liver. Now, there is this beautiful diagram illustration from the radiology article written by Dr. Barr and his group. And I thought I really liked the fact that when they try to give little illustrations to explain what happens as the liver worsens in steatohepatitis and eventually becomes cirrhotic. And what they're essentially trying to say is that initially, if you look at it, that the liver has only these very normal hepatocytes. As the liver worsens, you start seeing these lines of fibrosis that come up. These are the fibrotic lines, and the fibrotic lines keep increasing. Eventually, the round nodules or the regenerating nodules come over and increase their resistance to the liver. How do we now try to use elastography to find what is the speed of the shear wave and thus quantify the density of the liver? Simple techniques. The patient should be fasting. Patient can be supine or mildly decubitus and the right arm elevated above the head. Why is that? So that the intercostal space increases. We use the intercostal space to approach the right liver. We optimize the image. It's very important to optimize the grayscale image. We make sure that the transducer is perpendicular to the liver capsule. And then breathing is very important. Patients can be in quiet respiration, and then when you ask them to stop breathing, they just stop midway rather than taking in a big breath and holding. This requires some practice and essentially communication with the patient. So make sure you try this before you start making the measurements. The ROI, or the region of interest, is placed 1.5 to 2 centimeters below the Glissen's capsule. Why is that? Because it avoids reverberation artifacts. There is also a theory that you might have some subcapsular stiffness, which can be avoided by going about 2 centimeters deeper to the Glissen's capsule. Make sure the region of interest avoids large vessels and bile ducts. And essentially, historically, traditionally, because FibroScan used to do a mean value of 10 measurements, even with ultrasound, currently we are taking about 10 measurements and trying to find the mean value of the speed of the shear wave. So intercostal in supine position, or patient can be mildly decubitus onto the left side. Here is an essential image. We are about 2 centimeters deep from the Glissen's capsule. We have a region of interest. This is a 2D shear wave. And within that, we have put the measurement calipers. The measurement on this specific liver is about 4.26 kilopascal. We took 10 measurements. This one shows E3. That means this was the third measurement. When you go to the report page on the equipment, all the measurements are listed together. So E1 to E10, we have 10 measurements. They're pretty close to each other. And you can see that the median is about 4.23 kilopascal. What does that translate to in terms of speed? The velocity median is about 1.14 meters per second. So these numbers mean a lot, and I'll tell you in a second. There's one more number you have to keep an eye on, and that is the EIQR by median number. This is the interquartile ratio divided by the median. You don't have to try and go in detail about how this is derived, but it's important to know that this is always less than 30%. This is a quality measure, which means it allows you to know that the quality of your study has been fairly good. In this example, the quality is about 10%, way less than 30%, which means these numbers are fairly reliable. The quality measure is standing the test. So once we say this is 1.1 meters per second, what does it mean? And for this, I encourage all of you to look at this fantastic update to the consensus conference of the Society of Radiologists in Ultrasound, Liver Elastography. This consensus statement was updated and is available in the Radiology Journal of 2020. So we know that this case, which we saw in the previous, in this image, was about 1.14 meters per second. So if I go to this chart, I can see that 1.14 meters per second is less than 1.3 meters per second, which means high probability of being normal. And that is how you interpret. As you are going to make your measurements, this chart gives you a velocity of speed per second and also gives you the tissue density in kilopascals. So once you are able to coordinate with your numbers, making sure the quality is well maintained, you can make the diagnosis. And the diagnosis ranges from probability of being normal to the fact that you have conclusively ruled out a compensated advanced chronic liver disease, or that you rule in a compensated advanced chronic liver disease. Obviously, the last grade of 17 kilopascal or speed of more than 2.4 meters per second is highly suggestive of associated portal hypertension. We usually print one of the pages, and we've got a laminated sheet on our workstations to help us with daily interpretation. This is a nice slide which sort of gives you how the pathology shows increased reticulation and increased fibrosis, and how the elastography also tries to show increased speed, eventually helping us to come up with those correlations of the speed with the underlying fibrosis. Here's another example. This patient had about 3.9 kilopascals, 1.1, fairly well-placed ROI. And even this scale tells us that this is a fairly soft liver, not as hard as you would expect if you go higher in the kilopascals. Here's another example. Again, all 10 measurements. The IQR is here, which divided by the median gives you a 10%, which is a good quality measure. There are multiple confounding patients when we do elastography. Patient, if they have underlying diseases like acute hepatitis, biliary obstruction, hepatic venous congestion related to cardiac etiologies, if the patient took a deep inspiration rather than quiet breathing, patient is in a non-fasting state, large body habitus, these can influence the decisions, and I would say you should put that as a disclaimer in your impression in case one of these is associated with your measurements. The other confounding factor is vendor related. Different vendor equipments have different style, and there might be differences in the way they measure. There is obviously huge work being done in the background to try and standardize these measurements across different vendors. But nevertheless, initially, if you're following up patients with elastography for making a call on exacerbation versus resolution, I think it would be good to stick to the same vendor equipment which you have used for your early exams. The measurement location is important. Don't go too deep, because like anything in ultrasound, there is a lot of attenuation the further the sound has to travel. Can be transducer related, or the region of interest is inappropriate. Too large, too small, all those can have influence on the measurements you make. Here's an example again of a patient with some changes, little hyperechoic liver, and ROI has been put fairly large. This looks to be a pretty decent quality in this image. Sometimes confounding factors can be because of ascites and depth. Now, even though this seems to be logical, this is a cirrhotic liver, we know, we made a grayscale diagnosis on it. There is surface nodularity, there is ascites, and lo and behold, our numbers are also telling us that there is fibrosis happening in this liver. Now, in this example, if you see, we have much more heterogeneous appearance of the liver. The kilopascals is above 14. So this is a cirrhotic liver, and a fairly mosaic pattern is emerging within the ROI as you can compare with the scale next to it. So this is a cirrhotic liver. What happens when you have a situation like this? There is a lot of mottling. There is some areas which are not filling up. Now you wonder if our technique is okay. We do know that the Glisson's capsule is not perpendicular to the sound beam. So that might be one of the issue. Maybe the sonographer was trying to insinuate between the ribs. There's a rib here with a shadow. And in the process, she lost the ability to come and hit this 90 degrees. So these are small technical issues which really need to be looked at before you make a conclusion on the numbers. One of the ways to circumvent this is by addition of quality maps. A lot of vendors and a lot of newer equipments have a quality map which can be used to understand how good a quality of the exam is. And what happens now is that you have almost two split screens, one that is doing the elastography measurement, the second one is giving you a sense of the quality. This is the quality map, that is the elastography map. This tells us about density, this tells us about quality. And the lighter the hue of your box, the better is the quality. 100%, if it's very yellow, if it's somewhere a little back, that means about 80%, 90% quality, still acceptable. But if you're getting red, then that's bad quality. And I think the addition of the quality map has really helped in making more standardized, precise measurements across different sonographers and different patients. Here's another example of the quality map. You can see quality map is light yellow. That means fairly good quality, very homogeneous. And then we put a ROI here. You can't see the little ROI mark, but you almost can see it is about 6.1 kilopascals. So definitely some amount of early inflammatory changes are happening in this liver. You also see here E6, E7, which means two measurements was done. This is the advantage of using 2D shear wave. We can put two cursors in that. So that way you don't have to take many measurements. Earlier, we used to take 10 measurements with point shear wave. Now, even though we do 10 measurements, we actually may have to freeze only 3 or 4 times as we can put more ROIs in the same box. So it does reduce the time required to doing elastography. There are some examples of these technique-related pitfalls. You can see here again, the transducer, the Glisson's capsule is not 90 degrees to the transducer. We have some loss of information from within this ROI. So we can't really use this. This is technically inaccurate, and don't make a measurement on it. Here's a patient who has high BMI. You can see 5 centimeters already from the skin. So we are now almost 7, 8 centimeters. And generally they say within 4 centimeters, you get fairly decent results. So here we have a patient who's had too much attenuation of the sound beam and thus results in an unreliable result. Here's a patient in which the ROI is fairly deep. And not only the fact that it is deep, the patient also took a breath. Because the patient took a breath, you have these different hues, like cylindrical hues within the ROI box. It's not homogeneous. This is bad quality, and you would not use this to make your measurements. Here's another example of motion artifact. You can see patient took a breath, and because of that, you have these mosaic cylindrical artifacts. Again, very unreliable to make any sort of diagnostic measurement on this image. Here's an example in which the sonographer was overzealous and actually increased the transducer pressure. And when the transducer pressure was increased, then the proximal part of the liver actually showed a higher density because inadvertently got compressed. And you can see here, I think it's too close to the capsule for in the first place. You can see how the hue is bluish here and more reddish here, which means it's more stiffer. So this proximal part is stiffer than the distal part. So we know that we are dealing with an error secondary to transducer pressure. When you decrease the transducer pressure, the same liver is much more homogeneously filled up. And now you can put your ROI and you can get your numbers. We also talked about the ROI not having a vessel. This is an example of a blood vessel, maybe a venous channel going through. There is no signal there. So in a situation like that, just take a second measurement. Also make sure you understand that this is a 2D image, but the vessel is a 3-dimensional structure. It may be behind or above or in front of the liver parenchyma you are going to measure. So you can move the box away from the projected path of this vessel to avoid it completely. So towards the end, I want to bring your notice to this excellent illustration, which is again a part of the SRU consensus statement in the radiology journal. And this talks about likelihood ratio. Every color of the bar here correlates to a fibrosis grade. And we realized a couple of things, that when the shear wave speed goes up, at a certain point, the probability of diagnosing something confidently actually becomes lesser because the waves are coming closer to each other. We can always confidently say, oh, this is F4, so this is a cirrhotic liver, it's gone way up there. Once your speeds have gone above 2.1, you have a fairly high probability, more than 70%, that you are dealing with a cirrhotic liver. And likewise, once you are below about 1.0 to 0.9, you're pretty sure this is normal liver. But when you are in this zone, the likelihood ratios are going to guide you to some sort of overlap. And it's important to recognize this aspect and to recognize that there is a certain amount of limitation to what we can do using elastography alone. And these are the zones when the probability percentages are lower in our measurements, that we might even opt after that to do a biopsy so that we can confirm what we are suspecting. So going back to the chart about interpretation, it also reflects that those extremes, because when you are less than 1.3 meters per second, we are very confidently saying it's a high probability of being normal. Similarly, once you are above 2.1 meters per second, we are very confidently saying that this is chronically advanced chronic liver disease that is compensated. But when we start going in the middle zone, even the table says if you have measurements which are between 9 and 13 kilopascal, then yes, it is suggestive of compensated advanced chronic liver disease, but may need a further test for confirmation. And I think that is valid given what we just discussed in terms of this graph of likelihood ratio. This is very valuable. Make sure when you start out, you print this table and keep it by your side in your interpretations. So with that, we come to our last slide here. So in conclusion, a liver fibrosis, if detected at an early stage, has larger management options with potential for reversal. And that is where the role of elastography comes. Especially the shear wave elastography is an excellent non-invasive technique for estimating liver fibrosis and has certainly come of age in the current time. Emphasize the technique, make sure you do it correctly. I showed some examples of pitfalls, because if you do it correctly, you can lead to reproducible results, and there may not be much variation when you are following up the patient with the same study in 6 months to 1 year. Interpretation of the results must be made keeping in mind alternative mechanisms that may lead to error and elevate the liver stiffness than more than what it is. So background information, like does a patient have congestive liver disease or any biliary pathology, that should be kept in mind. So with that, thank you very much, and hope you start using elastography in your practice. It is fairly easy. It's a short learning curve. After you've done few, you'll realize that the time taken for this entire study is not more than 2 or 3 minutes once you've got the experience. Thank you very much.
Muchas gracias, doctor Dahiya, por su completa, didáctica y entretenida clase. La verdad es que la elastografía tiene principios físicos que a veces no son muy fáciles de entender, no son muy fáciles de explicar, pero con los ejemplos que vimos, la verdad es que a todos nos queda bastante más claro. Así que se agradece el esfuerzo que se nota que hizo por brindarnos una clase más accesible a todos que no tenemos tanta experiencia en elastografía. Vamos ahora a presentar a la doctora Amy Patel. Ella es radióloga especialista en imagenología mamaria, directora del Breast Care Center del Liberty Hospital, es profesor asistente de la Universidad de Missouri, Kansas, y es past president del Young and Early Career Program Section del Colegio Americano de Radiología. Además, para quienes no la conozcan, la doctora Amy Patel en Estados Unidos es uno de los referentes y líderes de prevención en cáncer de mama, promotora incluso a nivel legislativo y en otras instancias de participación social y comunitaria de normas y leyes para aumentar el acceso a mamografías, exámenes preventivos de imagenología mamaria. Así que la doctora Patel es una verdadera campeona de la prevención en patología mamaria, e incluso algunos miembros del Colegio Americano de Radiología se refieren a ella como una locomotora o un tractor que arrastra todos los proyectos en los que se involucra. Ella es muy famosa en Estados Unidos, así que le agradecemos el tiempo y la dedicación y la buena voluntad para compartir su experiencia en la elastografía mamaria con nosotros. Así que, doctora Patel, adelante con su clase.
Hello, my name is Dr. Amy Patel, and I am a breast radiologist, medical director of the Breast Care Center at Liberty Hospital in the Kansas City, Missouri area in the United States, an assistant professor of radiology at the University of Missouri, Kansas City School of Medicine, and immediate past chair of the American College of Radiology Young and Early Career Professional section. I'm so honored to speak to you today and delighted for the invitation to speak on shear wave breast elastography, present and future considerations. These are my disclosures. Now, in regards to breast ultrasound, both within the United States and internationally around the world, the market is seeing growth. And this is largely, particularly in the United States, due to sweeping breast legislation in dense breast patients. Now, in the United States, many of you may already be aware that we have dense breast notification laws in multiple states across the country, where in the report it is populated if the patient does have dense breast tissue, then she may require additional surveillance, such as in the form of breast ultrasound. And now we are seeing legislation at the federal level to create a federal mandate for dense breast notification. So with that is coming a sweep of breast ultrasound and breast MRI. Ultrasound is a tool that, of course, is being utilized more because it is much more accessible regardless of geographic location, and it is far cheaper. Now, the sensitivity has been excellent, but specificity continues to lack when it comes to breast ultrasound. And so we are always looking towards ways, new techniques that we can improve the specificity of breast ultrasound. So it's, of course, as a result, shear wave elastography is starting to really pick up steam and its utilization. It's truly on the rise due to increasing radiologist accuracy. As radiologists, we are always looking for new tools to ensure the most accuracy. And potentially, shear wave elastography could improve specificity concerns. So what is elastography and shear wave elastography? Well, elastography has actually emerged in the 1990s, so it's been around for quite a while. and it essentially evolved from the physician's manual palpation technique to detect tissue stiffness, as we know that when we perform a breast examination, when we are looking for something suspicious for malignancy, we're trying to feel for something that's fixed, firm, hard, immobile within the breast or along the chest. Whereas a mass that is palpable but more mobile may suggest a more benign process, such as a fibroadenoma or a cyst. So, shear-wave elastography can be used for breast, prostate, thyroid, pancreas, and we're even seeing this utilized in the musculoskeletal radiology world. And it's a highly reproducible technique and provides a qualitative value for the young elastic modulus of tissues by imaging the shear wave propagation within the tissues. Now, the stiffness of tissue is measured while under external pressure. Now, there are different types of elastography, so I want to briefly go over both of those. There is strain, where a transducer or acoustic radiation force imaging may be used to apply stress on the tissue of interest and assess stiffness. And then there is shear wave, which I touch upon more in this lecture, which is a newer method, and an ARFI pulse generates shear waves in a region of interest in a process called point shear wave elastography, or PSWE, or over a larger field of view using 2D or now newer 3D techniques. So recently, 3D shear wave elastography was introduced, and it offers the ability to visualize breast tissue in any plane of 3D volume. And that really allows the radiologists to preview information on the distribution of elasticity around and inside the lesion. We're getting more information by including that additional plane. Now, the speed of the shear wave, as measured in meters per second or kilopascals, indicates stiffness. So as a frame of reference, typically a stiffer lesion, perhaps a malignancy, may demonstrate a kilopascal around 180. But normal breast parenchyma that's devoid of any sort of malignancy or malignant etiology may be as low as 30 to 40. In regards to utilization of shear wave elastography, it can aid in the diagnostic evaluation of breast lesions, particularly figuring out if a mass, a lesion, area of interest is benign versus malignant. Now, we know on the whole that malignant lesions tend to demonstrate an increased tissue stiffness compared to benign lesions. But it must be noted that there are cancers that can be of the soft tissue etiology, so that's important to also make note. But on the whole, the stiffness is what we look at or evaluate when we are trying to figure out, is this a benign mass or a malignant mass? Shear wave elastography can also assist with targeting lesions using ultrasound-guided corneal biopsy. It can provide an accurate lesion size assessment, and of course now with the 3D component, even more accuracy is involved with that. It can also play a role in prognostics and monitoring of breast cancer patients during and after neoadjuvant chemotherapy. Again, another game changer, and elevates the way in which we practice, where we have 3D evaluation of modifications in the lesion's characteristics with 3D-B and 3D shear wave elastography, where you essentially assess lesion size and define the margins. This also can be employed when we are monitoring cryo and RF ablation. Now, the stiffness is displayed as a color map, and the soft tissues are coded in dark blue. Now, increasing stiffness will be coded in light blue, green, orange, and of course red, which typically denotes the stiffest. The color map can reduce the risk of false negatives due to artifacts. Now, when it comes to shear wave elastography, we have to beware of artifacts. and because these artifacts can result in false negatives. So the color map can really help in utilization to reduce artifacts and therefore that risk of false negatives. So a standard 5 centimeter wide linear transducer for breast evaluation is typically what is utilized, so whether it's 16 or 18. Higher frequencies should be used for evaluating superficial lesions, and then lower frequencies utilized for deeper lesions. Now, the risk of false negatives, as I've talked about in the subsequent previous slide, due to artifacts can occur, and that is something we must be mindful of when utilizing shear wave elastography. But it can be minimized, again, as I noted in the previous slide, by using a color-coded quality map to evaluate shear wave propagation and image quality. Now, combining strain and shear wave elastography can also help minimize artifacts, and that should be noted. Also, in regards to the technique, we must be mindful of pre-compression when it comes to shear wave elastography. Too much results in the lesion appearing stiffer than it actually is. So we obviously don't want a representation of something more stiff than it really is and leading us down the trail of could this be something more suspicious and does this warrant biopsy, which could result in a false positive. Now, you need to apply a large amount of gel, and it's important to, again, note that what your pre-compression is, because fatty tissue typically will appear as a dark blue. But if green or even red, it just indicates too much pre-compression has been utilized, and this needs to be corrected. So again, very important in the technique of shear wave elastography to be mindful of pre-compression. So in regards to the 3D acquisition process for shear wave elastography, the imaging transducer is connected to a motorized shaft that allows to sweep in an angular position. Now, to perform a 3D acquisition, a series of 2D images is collected along several planes, and the user can control the size of the volume sweep. So there's medium, large, or extra large typically. Now, once the images are collected, 2D information is then processed with a 3D scan converter to obtain a cubic volume that can be displayed on the screen. Now, the typical 3D B mode acquisition time is about 2 seconds. It's fairly quick. And then just with 3D shear wave with B mode, it's just a few seconds more, typically around 5 seconds. So this just demonstrates the 3D acquisition process. So from the 3D volume, arbitrary planes can be extracted for visualization. So the axial plane is parallel to the 2D imaging plane, which is your acquisition plane. And then the transverse plane is the plane perpendicular to the axial plane and perpendicular to the skin. And the coronal plane is perpendicular to the axial and transverse plane, parallel to the skin. This is an example of where we have a beautiful B mode 2D image, and we have a reconstructed 3D images in the axial, in the transverse, and the coronal planes. So from this beautiful B mode 2D image, we have these beautiful 3D reconstructed images where we can really analyze the margins of the lesion and the orientation of the lesion. Just beautiful characterization of the overall lesion. This is an example of a BI-RADS 2 lesion. So what we see here is in a 30-year-old female. There's quantitative shear wave elastography values. They were measured essentially by placing this region of interest within the lesion. So you want to try to get this region of interest just to cuff the lesion and make sure that the region of interest, the circle, isn't extended beyond the area of interest to just the normal breast tissue. We want it to encompass the lesion. And this was essentially a fibroadenoma. And again, noting that there isn't increased tissue stiffness to this lesion. Again, a BI-RADS 2 finding. Now, up on the opposite end, this is a BI-RADS 5 highly suggestive of malignancy lesion. This is actually a 60-year-old female, where you see on this beautiful B-mode image, you see this essentially this irregular, indistinct hypoechoic mass with an antiparallel orientation. The shear wave elastography image shows increased stiffness, and this is coded in this sort of red and orange area here. These little dots here as well, sort of reddish orange. Now, this increased stiffness that's surrounding the suspicious mass is known as the stiff rim sign, because the tissue is stiff in this peritumoral region here in comparison to the surrounding tissues or even the interior lesion tissues. So this essentially, this stiff rim sign is seen in the area of this peritumoral region. This is the same mass as a regular indistinct hypoechoic mass with an antiparallel orientation, but now you see this with the 3D reconstructed into 3D images. So you have your axial, your transverse, and your coronal images. So you can really look at the orientation, at the morphology, the margins of this area of concern, this BI-RADS 5 lesion highly suggestive of malignancy. Again, another example of a BI-RADS 5 lesion in the 65-year-old female, where you see this irregular and distinct hypoechoic mass with arguably an echogenic border here on this B-mode image. And the shear wave elastography image, which you can see here, is again what we see is coded more in red and orange or some green here in the peritumoral region, this stiff rim sign. And again, this is a sign that we typically see in cases that are suggestive of a malignancy. So again, a BI-RADS 5 lesion using the shear wave elastography method. So in regards to the future of shear wave elastography, we will likely see more widespread adoption of the technology as more radiologists find utility in evaluating tissue stiffness alongside B mode and other traditional ultrasound modes. I mean, in regards to ultrasound, we are always looking to downgrade lesions and try to reduce unnecessary biopsies. We know that typically around 80% of the biopsies that we perform end up being benign. So we are always striving to come up with new techniques and methods to reduce unnecessary biopsies. And shear wave elastography is another avenue in which we can potentially achieve that. Now, results of previous studies involving either static elastography or shear wave elastography have demonstrated that the combination of elastography with conventional ultrasound could achieve the best diagnostic performance. So there have been multiple studies in the literature since the advent of shear wave elastography. However, most of these studies tend to include a smaller number of patients, perhaps not generalizable across multiple practices and institutions, geographic locations. So more studies need to be performed in the field looking at shear wave elastography, where we essentially have a more diverse population, diverse data set, and of course a larger number of patients. And as there is increasing adoption of this technology, we are hopeful we will see that in the literature. Now, this article from Barr and colleagues sort of gives you a preview of what's to come for the future of shear wave elastography, or what efforts are being built upon. This was actually a study done back from 2010 to 2012, published in 2012, where Barr and colleagues analyzed 939 masses from 958 women who had repeat standard breast ultrasound and BI-RADS feature analysis, of course, coupled with shear wave elastography. What they saw was improved specificity of breast ultrasound mass assessment without loss of sensitivity. So by using the visual color stiffness to selectively upgrade category 3 and the lack of stiffness seen on shear wave elastography to downgrade category 4A masses, just looking at these alone, these BIRADs, the specificity improved from 61.1% to 78.5%, and the AUC increased to 0.962. So again, although a small number of masses on the whole in a small number of women, this is what we are seeing in the literature. And so if we can build upon these efforts to have a more diverse outlook, have increased number of patients across practice types, across geographic locations, not only in the United States, but across the world. This study was an international study, not just akin to the United States. We will likely see that this shear wave elastography is really the mainstay in the future of ultrasound and a large part of the field of the future of breast imaging. Thank you for your time. I really appreciate it. And again, I'm so honored to be here today to lecture on this topic with you.
Agradecemos a la doctora Patel por su excelente clase sobre el uso de la elastografía en mama. Personalmente creo que es una de las áreas donde va a tener mayor desarrollo en los próximos años debido a la importancia, la prevalencia y la morbimortalidad de la patología mamaria y a que está bastante superficial en comparación con otras estructuras que se estudian con ecografía. Así que yo creo que en el futuro viene muy fuerte la elastografía mamaria. Para aquellos que se dedican a esa área, estén atentos. Así que muchas gracias, doctora Patel. Y ahora, como tercera clase de este webinar, para hablarnos de patología tiroidea con elastografía, tenemos al doctor Richard Barr. El doctor Richard Barr es radiólogo especialista en ultrasonido y es el editor en jefe del Journal of Ultrasound in Medicine, que es una de las dos principales revistas de ultrasonido en medicina que existe en los Estados Unidos y la verdad es que a nivel mundial. Todos quienes participamos activamente de esta modalidad de estudio en imagenología, es casi una obligación para nosotros estar suscritos y leer las publicaciones que se difunden a través de esta prestigiosa revista. Así que es verdaderamente un honor para quienes amamos la ecografía que el doctor Barr esté haciendo una clase para Chile hoy con nosotros. Realmente me siento muy afortunado y les hago extensiva esa gratitud al doctor Barr y a todos quienes nos están escuchando. Además, el doctor Barr es profesor titular de la Northeastern Ohio Medical University y es alguien con mucha experiencia en ecografía. Así que, sin más, vamos ahora con la clase de patología tiroidea en elastografía junto al doctor Richard Barr.
Hello, thank you for inviting me to give this talk on thyroid elastography. I'm Richard Barr. I'm a professor of radiology at Northeastern Ohio Medical University and the editor-in-chief in the Journal of Ultrasound in Medicine. As you all know, thyroid lesions are very common, with 30% of adults and 50% of people greater than 65 years old. Ultrasound is highly accurate in the detection of thyroid nodules, but not highly predictive in the degree of malignancy. B-mode features of microcalcifications, marked hypogenicity, taller than wider, thick, irregular, or lobulated margins, and microcalcifications are predictive of malignancy. Sensitivities and specificities are considerably variable, ranging from 52 to 97%, and 26 to 83% respectively. We know from the literature for quite some time now that these, as listed here, ultrasound patterns have sensitivities and specificities that are suggestive of malignancy. And these features are all used in the various thyroids, and we don't have time to go through the thyroids. But this information is used by thyroids in different ways to come up with a probability of malignancy. Ultrasound-guided fine needle aspiration is the method of choice for diagnosis of suspicious lesions. However, the positive biopsy rate is very low. The American Thyroid Association recommends FNA of nodules greater than 10 millimeters or having suspicious features. Each of the ThyRADS organizations gives different guidance as to which lesion should be biopsied, and some are of higher sensitivity and some are of higher specificity, but the goal of ThyRADS was to decrease the number of FNAs of thyroids that are benign. The specificity ranges from 60 to 98% and sensitivities from 54 to 90% based on the ATA recommendations. Indeterminate and non-diagnostic results are common. They occur in up to about 10% of cases. A significant number of malignancies have adequate negative FNAs. And the overall false negative rate of thyroid FNA is 10.2%, meaning that 10% of your negative FNAs are actually cancers. And this can be reduced to about 5% with the second FNA. And 90% of patients with a false negative FNA had suspicious sonographic features. So re-aspiration should be considered in patients with sonographically suspicious nodules. There are two methods of using elastography for evaluation of thyroid lesions. These include strain and shear wave. So let's start with strain. The technique amount of compression and release varies with vendors. The strain technique requires some motion or compression of the tissues so that we can compare the differences in stiff use. And all vendors have a quality bar or number that allows a sonographer to optimize the elastogram to that degree of compression. We want to avoid patient motion, as with all elastography techniques. We want to try to eliminate the carotid artery pulsation effect by choosing the appropriate window and set the field of view so that the lesion is 50% or less of the image. Again, strain is a relative technique, so we need to have several tissues in the frame so we can give an estimate of the evaluation of the stiffness. For interpretation of strain, there are various color score patterns, either a 4-point or a 5-point system. We can also use what's called the strain ratio, where we compare the stiffness of the lesion to a reference standard. And in the literature, people have used the normal thyroid and have used the adjacent muscle. And some people like to use the muscle because in some patients with thyroid nodules, you may not have any normal thyroid in a reasonable place to be able to do the strain ratio. It's always important to remember that strain ratios are vendor specific. Each vendor has their own way of estimating the degree of strain so that the ratios are different. And the strain ratios vary based on the reference tissue. So cutoff values that are available for normal thyroid as the reference will not work for those as muscle as the reference. One of the common 4-point scales is that of Eugenio, where we have a score of 1, where the lesion is entirely soft, a score of 2, the nodule is predominantly soft with small areas of stiffness, a score of 3, presence of large areas of stiffness located in either periphery or central of the lesion, and a score of 4, the nodule is completely stiff. There's also a 5-point color scale, which is very similar to that that's used in breast. A score of 1, the lesion is very soft. A score of 2, the lesion has both soft and hard components. A score of 3, the lesion is stiff but smaller than it is on B mode imaging. A score of 4, the lesion is stiff and the same size as B mode imaging. And a score of 5, the lesion is stiff and greater than it is on B mode imaging. In the strain ratio, again, just to show you this example, what we're going to do is we're going to put one cursor in the nodule and one in the parenchyma, or you may be able to use the muscle depending on which you choose And the system will then calculate the stiffness ratio between the nodule and that reference standard. Again, the cutoff values will vary by vendor and by which reference standard you use. If we look at the variability between doing strain elastography, 6 studies have reported this, and the ratios or the K values are in the order of 0.6 to even 0.95. So moderate, good intra-observer variability. If we look at the results using the color scales, there are these 3 studies. The sensitivities are quite good, on the order of 95% or higher, as specificities of 80% or higher, and the negative predictive values in the high 90s. Interestingly, the positive predictive values for 2 studies, one was 55% and the other was 100%. If we look at the strain ratio results, not quite as good. Sensitivities on the order of 80 to 98% and specificities in the mid 80%. So here are some examples of benign thyroid. Here we've again put a ROI in the, let me grab an arrow for you here. We put a ROI in the nodule and an ROI in the normal tissue, and we get a ratio of 1.1, which is normal, and this was negative on FNA. However, here's another example from my lab of a nodule that was very stiff, and when we do this, the strain ratio is 5.0, highly suggestive of malignant lesion, but was negative both on FNA as well as on surgery. Again, given the marked hypoechogenicity of this lesion, we were very concerned that it would be malignant. Let's move on to the shear wave technology. We're going to use our linear probe with minimal pressure. Lots of coupling gel is very helpful. And here we don't want to move the transducer. We want to hold it very still. The patient is also going to hold their breath. As with all elastography, motion should be avoided. For real-time 2D shear wave, several seconds are needed for stabilization, and you can collect a cine loop and then go through and pick the best frames to do your measurements. Always, the transducer must be held still. Try to minimize movement from the carotid artery pulsations, which can be difficult. In the literature, the stiffness values for the thyroid gland are 2.0 plus or minus 0.4 meters per second, or 20.8 plus or minus 10.4 kilopascals. The literature has a wide range of cutoff values from 35 kPa to 66 kPa and 2.5 meters per second to 2.8 meters per second. And I think a lot of this has to do with the selection bias. Obviously, if we take all comers, we're going to have different results than if we select people that are highly suggestive of having a malignancy based on one of the thyroid scores. So again, when you're reviewing the literature, always look at that as to what patients they are recruiting. There are 4 meta-analyses that are available in the literature, and you can see that based on this, sensitivities and specificities are in the range of 80 to 90%. Some examples, here you can see the nodule, which is heterogeneous, and again, when we look at this, there are cystic areas that may be very soft. We want to choose those solid areas that are stiff to make our evaluation. And here you can see we've put our cursor. It's 140 kPa, which is very stiff, consistent with a cancer, and this was a papillary carcinoma. And again, you can also do strain ratio in shear wave by measuring the normal thyroid or muscle. Another case of a papillary cancer. Again, we can see some areas that may be soft and may be necrotic and or fluid, But again, what we want to do is look at those stiff areas and use that as our area to do our measurements. In our hands, we have seen a lot of cancers that have very low shear wave speeds. And here's an example of an FNA that was a papillary cancer, and the shear wave value is 26 kPa, basically almost the same as that of normal thyroid tissue. And in our practice, we've seen many of these, which has made us not cancel a thyroid biopsy if the B mode imaging was suspicious. We also see false positive. Here's a benign lesion that has a kPa of 4.3 and a ratio of 2.2, both suggestive of a malignant lesion, but was benign. We also have to be aware that there are artifacts. We can get lack of shear wave signal. Simple cysts, we don't see the shear waves so that they do not color code. Motion will always create abnormal or wrong results. We can also see a very strong shear wave at a skin surface called the bang effect, where that ultrasound push pulse is very stiff areas, an artifact by the skin surface. Obviously, calcifications will give us problems, and any motion either by the person doing the exam or the patient or the carotid artery are going to be confounding factors. We can also see sometimes stiffness around the capsule if the lesion has a very well-formed capsule. Sometimes we will get, what's a sense, reverberation artifact along the capsule, so be aware of that and don't take your measurements in those locations. Other limitations, inter-observer and intra-observer variability, more so for strain than in shear wave. Non-viscous fluids do not support shear waves and are therefore not color-coded. Viscous fluids do not support shear waves and code as soft or may not code at all. With point shear wave, the area of highest stiffness cannot be determined, and the sample box is placed based on the B mode imaging. So this creates another area of concern. We really should be doing 2D shear wave so we can evaluate the entire thyroid nodule based on that color stiffness map that we see. Small nodules, especially in point shear wave, the ROI may be larger than the nodule, resulting in inaccurate measurements, and cystic regions and calcifications will yield false results. Another area of concern is that follicular lesions in this study by Dr. Samir showed that the cutoff value was essentially the same as normal thyroid. So there's a huge overlap between follicular lesions as well as the normal thyroid. So it's almost impossible for us to pick up follicular lesions on shear wave elastography or even strain because their stiffness value is the same as background normal thyroid. The American Thyroid Association, by evaluating the meta-analyses, said that there was a wide range of cutoff values, therefore a threshold recommendation between benign and cancerous thyroid nodules could not be provided from this meta-analysis study. However, 3% of nodules that shear wave classified as benign were misdiagnosed nodules representing papillary cancers. And I would say in our practice that number is probably a little bit higher than 3%. And where we find clinically shear wave elastography is helpful is this patient is sent to us and say, biopsy the thyroid. And there's basically no normal thyroid. What we can do is do shear wave elastography and identify the lesions that are the highest stiffness and biopsy those areas because they will have a higher probability of being malignant. To conclude, malignant lesions are statistically stiffer than benign lesions, but there appears to be moderate overlap. So again, in our practice, I would say approximately 5% of papillary cancers will show up as being soft or below the cutoff value. And in our practice, we think that that's unacceptable. And cutoff values vary widely, as well as the sensitivity and specificity, as there may be less than a uniform technique being used. And I think that a lot of this has to do with selection bias. If the study is taking all comers, every nodule that we appear, you're going to get different results than if we used a thyroid scale to pick out the nodules that have a higher probability of being malignant. So again, when you're reviewing papers, take that into consideration. Additional studies are needed to standardize the techniques and interpretation. And to my knowledge, there's no good study correlating the elastography or adding it into THI-RADS. Remember, a negative elastography should not eliminate an FNA if B mode is suspicious, and should prompt FNA if the B mode or THI-RADS is suggestive of a positive lesion. I will also say that don't forget that surgical results show that FNA is wrong 10% of the time. We miss 10% of the cancers. So again, if you have very suspicious B mode or THI-RADS findings, even if the elastography is positive, you really should continue to do a second biopsy or send the patient to surgery, as what we do, because there is a high probability of an FNA having to be a false negative. So with that, I'm going to end. I hope that's helpful in this short period of time to talk about thyroid. Unfortunately, there is an overlap between benign and malignant lesions and stiffness, and it does add some information, but ideally we would have liked it to have a higher sensitivity and specificity, but it is helpful in helping to decide which nodules need to be biopsied. Thank you again for inviting me.
Muchas gracias, doctor Barr, por su excelente clase. Yo creo que al igual que en mama, la naturaleza superficial y de fácil acceso al transductor de la glándula tiroides va a hacer que el uso de la elastografía aumente mucho en los próximos años. Yo creo que hay mucha investigación en desarrollo y va a ser cada vez más. Y estoy seguro que más temprano que tarde, va a ser una herramienta indispensable en la evaluación de los nódulos tiroideos. Así que es bueno que tengamos la posibilidad de conocer esta modalidad de estudio. Le agradecemos nuevamente al doctor Barr por su excelente clase. Y ahora, para finalizar este webinar, vamos a cumplir con una obligación contraída con nuestro auspiciador Data Médica, representante Mindray en Chile, y que ellos nos pidieron como auspiciadores de esta actividad de educación médica continua que les contemos a ustedes sobre el último producto que ellos traen a Chile en el mundo de la ecografía y que está completamente relacionado con la elastografía, que ha sido el tema que hemos visto junto a los distinguidos colegas que nos han acompañado. Así que yo les voy a dar unas muy breves palabras sobre el equipo más nuevo de Mindray, que es el Resona 9, y que es un tremendo equipazo. Yo como ecografista, alguien que hace ecografía permanentemente todos los días en gran cantidad, quise escoger los puntos que a mí me parecían más relevantes, más allá de las cosas que cada empresa dice sobre sus productos. Esto para empezar a conversar un equipo diseñado para estar en la cima de la ecografía actual, lo que coloquialmente se conoce como tope de línea. Es un equipo hecho para pelear de igual a igual con los grandes. Y tiene algunas particularidades tecnológicas que yo las encuentro muy apasionantes. La primera es que no requiere foco. Así como escucharon, este equipo tiene una tecnología de procesamiento de imágenes en la cual todos los niveles de la imagen están siendo enfocados al mismo tiempo, desde el más superficial hasta el más profundo. Y por lo tanto no hay que estar moviendo uno o más focos dependiendo del lugar específico que nosotros queremos explorar, sino que toda la imagen de arriba a abajo está enfocada por completo al mismo tiempo. lo que es una gran comodidad para los que hacemos ecografía. Además, este equipo tiene tremendas capacidades de elastografía, utilizando las últimas tecnologías disponibles en el mercado, y viene con los software necesarios para hacer elastografía de abdomen, de mama, tiroides, musculoesquelética, prostática endorrectal, etc. Tiene otra tecnología que tiene que ver con el mundo de la ultrasonido Doppler, que es que no requiere ángulo. Esto ya vulnera todo lo que hemos estudiado de la ecuación Doppler y el funcionamiento del Doppler, pero la verdad es que una técnica, una tecnología muy novedosa que se llama análisis por flujo de vectores, que es capaz de forma automática el equipo detectar la velocidad y dirección de los eritrocitos en los vasos sanguíneos de manera independiente del ángulo. Por lo tanto, nos despejamos ese problema típico del ecografista Doppler, de si está bien el ángulo para medir la velocidad. Y les voy a mostrar más adelante una imagen cómo el equipo hace todos los cálculos Doppler en forma automática. Además, tiene un módulo para hacer procedimientos ecoguiados, punciones, biopsias percutáneas, con todas las herramientas y sistemas especialmente diseñados para ello. Y además es un equipo que viene listo para el uso de contraste ecográfico, que si bien aún no llega a Chile, yo les aseguro que más temprano que tarde va a aparecer el contraste acá. Ya se usa en varios países del mundo, Europa, Estados Unidos, etc. Somos de los poquitos que todavía no tenemos contraste ecográfico. Habemos muchos colegas que no hemos formado en esta técnica afuera, así que apenas llegue el contraste ecográfico, es bueno tener un equipo que ya venga listo, porque vamos a empezar de inmediato a incorporar esto en nuestra práctica habitual. Esta es una imagen en escala de grises. Les quiero mostrar, fíjense que en la escala numérica que está al lado no existe ningún foco. Y esto se debe a que no se ocupa foco en este equipo, y toda la imagen está uniformemente enfocada desde el sector más superficial adyacente al transductor hasta el más profundo que se alcanza a ver acá, diafragma. Fíjense cómo todo está completamente enfocado. No existen zonas más o menos enfocadas, lo que es muy cómodo para el ecografista. Acá una muestra de lo que es elastografía. Fíjense qué buena resolución espacial de los mapas colorimétricos, con posibilidad de pantalla dual, e incluso ahí un marcador de localización y orientación del transductor y todas las mediciones respectivas. Full elastografía en el contexto de lo que vimos en estas estupendas clases en este webinar. Y acá lo que les contaba del flujo de vectores, acá tenemos el color Doppler clásico, una bifurcación carotidia, venita en azul, arterias en rojo, todo bien, pero miren qué distinta y atractiva es la información con flujo de vectores. Todas las flechitas se mueven en una dirección determinada, y además cada flechita se mueve a su propia velocidad de acuerdo a lo que determina el equipo. Fíjense que la vena va para un lado, las arterias van para otro, y los distintos colores significan distintas velocidades. Y ver esto en movimiento es muy muy bonito, es una verdadera sinfonía de flechitas viajando por los vasos sanguíneos. A mí me encanta, la verdad. Y fíjense cómo en el caso del color Doppler, la caja está angulada, porque tenemos que angularlo en relación al flujo. En cambio acá, la caja no está angulada, está en 90 grados, caja cuadrada, e igualmente se determina el flujo, la dirección del flujo y la velocidad. Esto para mí es extraordinario. Acá tenemos otro muestra de flow. Este es de menor resolución la imagen, pero ahí se pueden ver las flechitas. Y fíjense todos los valores que apretando un botón les da en forma automática al sistema. Velocidad pic sistólico, velocidad media, aceleración, flujo, volumen, lo que quieran en forma automática. Esto facilita mucho, mucho, mucho la evaluación Doppler, y permite que ecografistas que a lo mejor no tienen tanta experiencia en esta técnica puedan realizar los exámenes adecuadamente con el apoyo de esta herramienta. Y de las características más físicas del equipo, tiene una pantalla táctil de 13,3 pulgadas, tiene una cosa que a muchos colegas con los que yo he conversado les gusta, que tiene un teclado físico con botoncitos para apretar. Hay colegas que no les gustan los teclados en pantalla táctil, así que para ellos, acá, su regio teclado con botoncito, monitor LED de alta resolución, perillas de muy buena sensibilidad y multifuncionales, y se le pueden conectar hasta 5 transductores al mismo tiempo y tiene una batería que puede durar hasta 24 horas en modo espera. Pese a lo moderno que es, fíjense que no es un equipo voluminoso, así que cabe bien en casi cualquier salita de ecografía. Y tiene sus rueditas si lo queremos llevar a la UCI o a otro lado. Así que eso sería lo que quería compartir con ustedes respecto a este equipo, el Resona 9 de Mindray. Y bueno, para terminar, darle nuevamente las gracias a nuestros expositores internacionales, doctor Dahiya, doctora Patel, doctor Barr. Muchas gracias por dedicar su tiempo y experiencia a este webinar de un país tan pequeño y alejado como lo es Chile. Estamos muy agradecidos. También gracias a Datamédica y Mindray por proveer el financiamiento para poder pagar la plataforma informática, hacer la difusión y todos los costos involucrados en esta actividad para que pueda ser totalmente gratuita para los participantes, de acceso liberado, universal y con tan destacados profesores extranjeros. Y por último, agradecerle a ustedes por quedarse hasta esta hora, por estar preocupados por aprender más, por conocer nuevas técnicas, nuevas modalidades, y los invito a seguir en eso. Yo creo que la elastografía va a empezar a despegar fuerte ahora en Chile, y es bueno saber de qué se trata y estar preparado. Muchas gracias.